very much for attending this presentation, and I will be beginning with our first topic, which is biomarkers in oncology. So let's first begin with a quick definition of biomarkers. What is a biomarker? We can define it as a biological molecule that we find in the blood, the fluids, the tissues, that is considered to be a sign of a normal or abnormal process or disease. All right, there's a tremendous variety of biomarkers. They can be proteins, they can be enzymes, receptors, nucleic acids, microRNA, they can be receptors, antibodies, etc. And they are produced as a result of an alteration of gene expression or some type of proteomic or metabolic signature. So, where can we detect these biomarkers? We can detect them either in the circulation of the blood, in the excretions, such as the urine or the stool. We can detect it in the secretions, such as the sputum, and we can derive it from the tissues through biopsy. Now, genetic biomarkers are particularly important, and we're going to talk about them very soon. These are considered to be either inherited as germline DNA, for example, a mutation in BRCA, or they can be somatic and therefore detected as mutations in tumor tissue DNA. So now that we know biomarkers, let's talk about tumor markers. These are considered to be specific biomarkers that we use in order to check for the presence of a tumor. There's a very wide variety of tumor markers actually, and this is a very short list. We can just, like mentioned, thyroglobulin, which is used to detect tumors of the thyroid gland. AFP, levels of which, if they increase, detect some type of damage in the liver. So it could be liver malignancy, cancer, or otherwise. So let's move on and talk a little about cancer. It's a relatively autonomous growth of tissue. It can be spontaneous mutation, or it can be caused by a carcinogen. A carcinogen can be physical, radiation. It can be chemical, as a polycyclic hydrocarbon, or it can be biological, as a virus hepatitis C, which causes hepatocellular carcinoma in the late stages of the disease. Now, a carcinogen, as a general rule, will cause one of two things to cause cancer. Either a genotoxic effect on the DNA, or increased cell proliferation, or both. So, let's talk a little about the statistics of cancer so we know what we're dealing with. Here we see that prostate cancer is the leading cancer in men, with breast cancer the leading cancer in women. In 2015, there will be an estimated 1.6 million new cancer cases, of which 600,000 people will die. And in 2012, 14 million new cancer cases were recorded, resulting in 8 million deaths. So obviously, this is a problem that we need to solve, and it is through early detection. It offers the best opportunity. And we're going to talk about how we can revolutionize the treatment of cancer through early detection. Okay, so now we want to talk about the uses of tumor markers. Very briefly, we can say that tumor markers are used for estimating the risk of developing cancer, where if we detect some type of mutation in BRCA1, this is considered to be a high probability of the development of breast cancer, and to a lesser extent, ovarian cancer later in life. Then we've also got another use, which is screening. Prostate-specific antigen can be used for the screening for prostate cancer in males. Then we've also got differential diagnosis. If we want to know whether the cancer is primary or secondary through immunohistochemistry methods. And then we've also got the fourth function, which is predicting the response to therapy, where if we find an increased level of estrogen receptor expression within breast cancer, then hormonal therapy would be adjuvant, where we can use tamoxifen, for example. The fifth function is monitoring for disease recurrence, where following colorectal cancer, if there's an increased level of carcinoembryonic antigen, this usually indicates metastasis to the liver. And then the sixth and final function is monitoring progression in metastatic disease, where we find increased levels of CA15-3 or carcinoembryonic antigen. This is indicative of metastasis in breast cancer. So let's move on and talk about how we can analyze these tumor markers. We can analyze the enzymatic activity through an enzyme assay. We can analyze it through immunoassay methods, antigen-antibody reaction. This is an example of a device that we actually have over here in the clinical pathology department that employs immunoassay methods. And this is a quick diagrammatic representation where a labeled antibody will produce a specific reaction, chemical reaction, from which we can identify whether a specific particle is present in the solution or not. So, we've also got a number of molecular techniques, and these are particularly important with nucleotides. And we've got polymerase chain reaction for the amplification of DNA. And this is the device that we actually use in this clinical pathology department, a very advanced device. And then we've also got DNA sequencers, and this is an example of a device that is used to analyze the sequences of nucleotides in a DNA sample, adenine, guanine, or otherwise. Finally, we've got two other techniques by which we can analyze tumor markers, and this is through mass spectrometry or a receptor assay, and this is considered to be an example of device used in mass spectrometry. All right, now let's move on and talk about the types of tumor markers. We're almost done over here. Okay, so the first thing we want to start with is the enzymes, one of the very first group of tumor markers. They are relatively non-specific except for PSA, and they are analyzed with the immunoassay techniques, as we mentioned. All right, so the very first one we can talk about is ALP. ALP is considered to be increased in cases of primary and secondary liver cancer, to a lesser extent as well in leukemia, sarcoma, lymphoma, and we've also got a variant of ALP, which is placental ALP, seen in other types of cancer, such as lung, trophoblastic, GIT, and otherwise. Then we can also move on to prostate-specific antigen, one of the very important enzyme tumor markers we have, actually. It is considered to be highly specific, as a matter of fact, and it is considered to be secreted by the epithelial cells of the prostate gland, released into the circulation, present in two forms, either the free form or bound to either anti-chemotrypsin or alpha-macroglobulin. So why is this important? Because when we plot the ratio between free PSA and total PSA, this can be highly indicative of the development of prostate cancer, where if the ratio is between 10 to 15, this indicates a 55% probability of development of prostate cancer. So it's a very important enzyme tumor marker that we have. Let's move on. We've got hormones. Hormones are also considered to be important tumor markers, analyzed by immunoassay methods as well. And we can talk about ACTH, adrenocorticotropic hormone, which is considered to be produced by the corticotropic cells of the anterior pituitary gland. Now, it is elevated in cases of small cell carcinoma of the lung, and this is a very highly metastatic type of cancer. So, we've also got HCG, human chorionic gonadotropin. This is seen in cases of tumors of the testis, as well as the placenta. Of course, if the cancer of the testis is allowed to develop, it usually results with metastasis to the lungs. So obviously, if we can detect the levels of HCG early, we can avert this problem. And we can also see HCG increased levels in tumors of the placenta. Then we move on to the oncofetal antigens. These are considered to be tumor markers that are present during fetal life, and then they may be increased in cases of cancer. The first example is AFP, alpha-fetoprotein. As we can see in the diagrammatic representation over here, or the graph, it increases during embryonal and early postnatal life. However, it does increase in cases of hepatocellular carcinoma up to 200% of the normal levels. And it may also increase to a lesser extent in teratocarcinoma, so AFP is particularly important as well. And then we can also see carcinoembryonic antigen, CEA, seen in many different types of cancers, so it's not specific, but it is still important nonetheless. And here we've got a diagrammatic representation, a CEA tumor cell. It expresses the antigen, and the immune system interacts with it in specific fashion. Finally, we go on to carbohydrate markers, also particularly important, can be antigens, or they can be secreted by the tumor cells. All right, so we can look over here. The stages of breast cancer are considered to coincide with the increasing concentration of carbohydrate antigen 15-3. So we can monitor for the progression of breast cancer through this very important tumor marker we have over here. All right. Then we come to the final aspect of the presentation, which is genetic and molecular markers, a particularly important aspect of tumor markers. We mentioned that genetic alterations can be the cause of cancer, where they can cause transformation of a normal cell to a cancer cell, or they can allow for the spread of cancer. These can function as oncogenes or tumor suppressor genes. So let's begin with BRCA1 and BRCA2. These are very important, where if a mutation is detected in BRCA1 in females, this is highly likely for the development of breast cancer and to a lesser extent ovarian cancer, as we mentioned earlier. So let's take a look at this graph over here. Here, if there is a BRCA mutation, breast cancer increases to a probability of about 33 to 50% by age 50 and up to 87% by age 70. So it's very important to detect some type of mutation and therefore employ techniques in order to minimize the probability of development of breast cancer. And now we come to the last aspect of our presentation, which is microRNA. Now, microRNA is considered to be one of the revolutionary things that we've discovered in the past few years. It is considered to be a non-coding piece of nucleic acid material. This is important for the regulation of post-transcriptional gene expression, or protein biosynthesis. Different microRNA molecules, if discovered, or detected actually, they are considered to be specific for different types of cancer. And microRNA is considered to have the capability or the potential to be the most accurate diagnostic tool we have for cancer in the possible future. Now we can look at this representation, how microRNA normally blocks translation and therefore controls a normal rate of growth and proliferation. It can function as a tumor suppressor gene, in which if it is not released properly, oncogenes will function uninhibited, leading to the formation of oncoproteins and the eventual tumor formation. Or microRNA can function as an oncogene, where it will inhibit the tumor suppressor genes and therefore also lead to tumor formation. So before I wrap up my presentation, I would just like to present to you a video demonstration of an individual known as George Soto. He is a cancer technologist who is was very interested in microRNA and has devised some very beautiful techniques for the analysis of microRNA. This is a TED Talk in 2014, so without further ado, let's run the video.
Let me do a demonstration. Imagine that next time you go to your doctor and do your next standard blood test, the lab technician starts the total RNA, which is quite simple today, and puts it in a standardized well plate like this one. Each one of these plates has specific biochemistry at this time that is looking for a specific microRNA, acting like a trap, that closes only when the microRNA is present in the sample. And when it does, it will shine the green color. To run the reaction, you put the plate inside the line like this one. And then you need to put your smartphone on top of it. If we can have a camera here, so you can see my screen. A smartphone is a connected computer, and it's also a camera. Good enough for a purpose. The smartphone is taking pictures, and when the reaction is over, we'll send the pictures to our online database for processing and investigation. This entire process lasts around 60 minutes. But when the process is over, we'll start shine our match to the specific microRNAs and analyze in terms of how much and how fast they shine. And then, when this entire process is over, this is what happens. This chart is showing the specific microRNAs present in this sample and how they reacted over time. Then, if we take this specific pattern of microRNA of this person's samples and compare it with existing scientific documentation that correlates microRNA patterns with the specific presence of a disease, this is how pancreatic cancer looks like. This inside is a real sample where we just detected pancreatic cancer. Since we believe early cancer detection should really be democratized, this entire solution costs at least 50 times less than current available methods. And we know that the community can help to accelerate this even more. So we make the design of the device open source.
That the closest thing we have to a silver bullet for the treatment of cancer is early detection. The earlier we can detect cancer, the easier we can treat it. With microRNA, we can hope that one day the treatment of cancer will be like the treatment of the common cold. Thank you.